In a field hospital after a battle, a wounded man is lying on a wooden table while a surgeon looks at his leg and makes the decision everyone in the room already fears. The bone has been smashed open, dirt has been driven into the wound. The bleeding can be slowed, but the deeper problem is waiting under the skin. Once the flesh begins to rot, the danger can move upward through the body. The man does not need a miracle. He needs the surgeon to remove the leg before the leg removes him from the world. That is the strange question at the center of this story. What kind of world makes a person choose to be cut apart while awake, not because people were cruel for no reason, but because agony seemed like the only path left between life and death? For centuries, one of the most painful ways people survived was amputation before modern anesthesia and before doctors truly understood infection. A limb was crushed by a cannonball, torn by machinery, broken open by a cartwheel, or poisoned by a wound that would not heal, and the answer could become brutally simple. Take it off quickly, or wait for the body to lose the fight. The person on the table had a clear goal. Keep the wound from spreading. Stop the bleeding before weakness took over. Remove the shattered part before fever and darkened flesh turned one injury into a whole body collapse. The obstacle was that the people trying to help him lacked almost everything we now imagine as basic. They did not have reliable anesthesia until the mid-19th century. They did not have antibiotics. For much of this history, they did not understand that invisible germs could enter a wound and multiply there. They could see pus, smell decay, and watch fever rise, but the deeper cause was hidden from them. So pain became part of treatment, not because pain healed anything by itself, but because the useful action was trapped behind it. Before ether and chloroform changed surgery, surgeons had to think about pain as a race against time. A slow operation could be dangerous. Patient might thrash against the assistants holding him down. He might faint, bleed heavily, or go into shock. The longer the cutting continued, the more the room filled with panic. A good surgeon needed knowledge, a steady hand, and speed. This is why men like Robert Liston became famous in the early 1800s. Liston was a Scottish surgeon known for operating with terrifying speed in the years before anesthesia. In that world, speed was mercy. A surgeon who could remove a limb in a few minutes gave the patient less time inside the pain, less time to struggle, and less time to lose blood. Imagine what that meant in practice. Assistants grip the patient's arms and shoulders. Another controls the damaged limb. A tourniquet is tightened above the wound to reduce blood flow. The surgeon takes a long knife and cuts through skin and muscle. The flesh is pulled back, so there will be enough tissue to cover the stump later. Then the saw comes out, and the bone has to be cut through by hand. The worst part is that everyone in the room understands the logic. The surgeon is not trying to torture the patient. The assistants are trying to keep him still enough for the operation to end before his strength fails. The man on the table is enduring it because a dirty, shattered limb can become a sentence, and this is the only appeal available. In military surgery, the decision became painfully common. During the Napoleonic Wars, surgeons faced injuries that household medicine could not touch. A musket ball might tear through flesh and carry cloth into the wound. Artillery could crush limbs beyond repair. Horses, wagons, and boots moved over ground filled with blood, mud, and waste. If a soldier lay too long, the wound did not stay as it was at the first moment. It swelled, darkened, and became warm, foul, and dangerous. Dominique-Jean Larrey, Napoleon's famous surgeon, helped transform battlefield care by moving wounded men away from the fighting faster and sorting them by urgency rather than rank. That idea sounds humane now, but it also meant more men reached surgeons while there was still a chance to act. What could be done was often what they feared most. If the limb was beyond saving, hesitation could cost the patient his life. The brutal part was that amputation could save someone and still fail him. Even after the limb was removed, the danger was not over. The wound had to heal in a world where instruments were not sterile in the modern sense, hands were not cleaned with today's understanding, and hospitals could be full of infection. The patient might survive the table and then die days later from fever, pus, or blood poisoning. People knew the pattern, even if they did not know the microscopic reason. That is what made the choice so harsh. Refusing the operation did not mean choosing comfort. It often meant choosing the slower path. A crushed limb could keep bleeding. A compound fracture, where bone pierced through skin, could become infected with frightening speed. Gangrene could turn tissue dark and lifeless, and once the rot spread, the body might follow. The patient and surgeon were comparing pain now with the possibility of death later. This is the point that is easy to miss from a modern room. People in the past were not too stupid to notice that amputation was awful. They heard the screams. They saw patients tied or held down. They watched the sawdust mix with blood. They understood that the operation could break a person's mind as much as his body. Yet they also lived close enough to untreated wounds to know what waiting could look like. Waiting could mean the smell of decay rising from your own leg. It could mean fever dreams while the skin around the wound changed color. It could mean family members watching the infection climb day by day, hoping the body would somehow stop it, while everyone quietly understood that hope was not a tool. A surgeon with a knife and a saw was terrifying, but helpless waiting could be worse, because it gave the illness time to choose the ending. The arrival of anesthesia in the 1840s changed the emotional shape of surgery. In 1846, ether was publicly demonstrated in Boston as a way to make surgical pain disappear, and the idea spread quickly because it answered a question operating rooms had been asking for centuries. What if the body could be opened without the patient feeling every moment of it? For the first time, the screams were no longer treated as an unavoidable part of the work. The table became quieter. Surgeons could move more slowly and carefully. Patients no longer had to measure survival through raw endurance alone. It changed what a person had to be willing to suffer in order to live. But anesthesia did not solve everything. A patient could sleep through the cutting and still wake into a world where infection waited. Surgeons could perform longer operations, but wounds could still turn septic afterward. The missing piece was not just the defeat of pain. It was the understanding that dirt, instruments, dressings, and hands could carry danger into the body. That is why the work of Joseph Lister in the 1860s mattered so much. Inspired by the idea that tiny living things could cause decay and infection, Lister used carbolic acid to clean wounds and surgical materials. His methods were not gentle, and carbolic acid could irritate and burn skin. Yet it pointed surgery toward a future where survival did not have to depend only on speed, luck, and the patient's ability to endure. In 1865, Lister treated an 11-year-old boy named James Greenlees after a cartwheel caused a compound fracture in his leg. In an earlier period, that kind of injury often led surgeons toward amputation because an open fracture could become infected and fatal. Lister used carbolic acid dressings and managed to save the limb. The treatment was rough, but the meaning was enormous. A wound that once might have forced a child toward the saw could now be approached differently. That shift helps explain why pre-anesthetic amputation feels so disturbing now. It sits between two truths that are hard to hold together. The operation was violent, painful, and sometimes deadly. It could also be the most rational decision available. The surgeon's knife was not proof that people cared less about suffering. It was proof that they were trapped inside a smaller set of choices. A person with a crushed limb did not need medicine to be perfect. He needed it to be better than the wound. Before anesthesia, the operation had to outrun pain. Before antisepsis, the wound had to outrun infection. Before antibiotics, the body had to finish the battle almost alone. Survival depended on the surgeon's speed, the patient's strength, the cleanliness no one fully understood, and the luck of whether the invisible enemy had already entered too deeply. So the most painful way people survived before modern medicine was not pain for pain's sake. It was the moment when pain became the door that had to be crossed because every other door was closing. The man on the wooden table was not choosing agony because he misunderstood the cost. He was choosing it because the crushed limb, the spreading infection, and the slow fever behind it had already made their own offer. The surgeon's knife was terrible, but it was also action. It was the one thing that suggested the future might continue. That is the answer to the question. Before real medicine, pain was sometimes not the thing people were trying hardest to avoid. Pain was the price placed in front of life, and in the most desperate moments, people paid it because the alternative was to lie still and let the wound decide everything.